chairperson, for the kind introduction. May I have the slide set, please? All right. So we heard two excellent talks on acute leukemias, needless to say, more aggressive and more challenging diseases. And now I will take you through disease CLL, which is, much more calming for an oncologist to treat. The maximum number of breakthroughs in CLL have been, next slide, please. Yeah, have been seen in last 2 decades only. And before that, there was a kind of a long period of lull as far as any advances in either diagnostic or therapeutic options were there in the field of CLL. So to enjoy breakthroughs, we really need to know first what we have broken through. Next slide. Yeah, so 1924, I am taking you back in time. And this was probably one of the first systematic report of CLL patients who were treated with only radiotherapy. Next slide. The next slide. Please change slide. Yeah. No. Back by one slide. Yeah. So in that paper, you can see I found two very striking points. Number one, that average duration of diagnosis of CML was 1.4 years after the onset of symptoms. Nowadays, we see patient coming with just high TLC and they are diagnosed as CLL if they are having it. The second point is all these patients were treated only with radiation and it did not work. Now from 24 to next 40 years, there was practically nothing. Next slide. So I consider this to be the major breakthrough in the history of CLL. 1950s, 1960s, you can see two different papers. By Golter, 1955, they first published role of chlorambucil, and within a span of 5 years, a role of single agent steroid by Esden et al. And they found that the response rate were in the tune of 40 to 50%. They were overall response rate. Needless to say, there were no CRs. However, this was the first major breakthrough in the field of CLL. And from 50s to 60s, there was again a big quiet period till the 21st century. Next slide. Yes. So you can see from mid 20th century, now we are standing at the beginning of 21st. It was almost same. One alkylator with a steroid, with some supportive therapy and transfusion. And see, this is the way CLL used to be treated. Next, please. Yes. So I consider that the breakthroughs which we are going to discuss are going to be relevant today happened in last 2 decades. I have tried to classify them in 3 different parts. Number one is early 2000s, which is development of targeted anti-CD20 antibodies. Number two is 10 years later, development of advanced biomarker, and rather I should say enhancement of our understanding of biology of CLL, which has greatly improved outcome of these patients. And lastly, the talk of the town, these new small molecule inhibitor of the B cell pathway. Next, please. Okay, so beginning with the most famous drug, most hemato-oncologists love this drug for its versatility. And I'm going to show you some very brief data in CLL. Next, please. Next slide. Yeah. So this is a 3D model of protein, which is immunoglobulin called rituximab. If you see these two yellow blocks, they are the variable region. And this large block on your left is basically the FC portion, presumably the most important part of an antibody. Next. Next slide. Is showing the same thing. Next, please. Yes. So I think I would like to draw the attention on mechanism of action of rituximab. Most of the people in the audience of this talk already know it, but I would like to reiterate again. If you see the blue circles in this diagram, on the top we have complement-dependent cell cytotoxicity, which is one of the major mechanism of rituximab. On the right side, we have two blue circles, ellipse. You can see ADCCs, antibody-dependent cell cytotoxicity, which is another mechanism. I'm going to use these mechanism later in my presentation. And on your right, you can see direct cell death is one unknown mechanism through which cell die after being treated with these monoclonal antibodies. So this is the mechanism. Next, please. Yeah. So these were few earlier studies. If you see, the seminal studies were basically done by Suzanne O'Brien and John Bede. And these studies were single agent rituximab studies in patients who were previously treated CLL. In that cohort also, if you see this red block, the response rate were around 50%. So CLL, we used to have only chlorambucil and some steroids. And after the progression, we had nothing much, just to retreat with the same kind of combination. Now, for the first time, without any chemotherapy, only with monoclonal antibody, somebody showed overall response rate of around 50%. Some of them were complete response. So I think this was the arrival of rituximab in CLL. And in the modern era, after the development of chlorambucil, this is the breakthrough. Next, please. Yes. So now we have seen rituximab is on the platform, single agent, very active. Needless to say, it led to development of combination of rituximab with chemotherapy. Next slide, please. Okay. So we all know, all practitioner of hemato-oncology, these are the classical combination with rituximab, either in combination with fludarabine or bendamustine or chlorambucil. All three combination are used by us even today in different kind of setting. I'm going to give you just some glimpses of the same. Next, please. Okay, so CLL kind of study. This is one of the landmark study in the field of CLL, which established chemoimmunotherapy in some form. Next slide. Next, please. Next. Yeah. So this is a design, and this can be a prototype of an excellently designed randomized controlled trial with very focused objective. The good patient number 564, they were almost equally randomized to FCR versus BR, and they were followed up for response rate as well as survival. Next slide. Okay. So you can see the blue line is for FCR and the green line is for BR. And as the time is passing towards 5 years, the gap is widening in between them. Next, please. So we can infer that FCR arm was clearly better than BR for PFS, and this benefit was not small. It was up to the tune of 13.5 months. Next slide. However, this slide was very humbling. Next, please. You can also say that despite giving a drug combination like FCR, which is pretty toxic, there was no overall survival benefit. So PFS was better and OS was same. This is a story of CLL10, and we are still seeing the repetition of same results even with the modern molecule, which I am going to discuss in the later part of my presentation. Next. Next, please. You can remove this slide. Go on. Yes. So I'm coming to the second part of, yes, stay there. So I'm coming to the second part of my presentation. After discussing the development of rituximab, its efficacy and application in CLL, let's move to highlight an area of unmet need. Next, please. So that is the second aspect of the presentation, that we had a drug, rituximab. We had very nice combination like FCR. However, still there was a lack of a very reliable biomarker for CLL, which can help us to differentiate patients who were different from others. Next slide. Okay, so you can see in this slide, we have 4 graphs. Next, please. And in this slide, okay, and you can see the below 2 curves, this is a follow-up of 5 years, are constantly falling. Even after a follow-up of 5 years, there is a constant fall in the outcome of these patients. This is a survival curve. And the difference which turned out to be was not the chemotherapy, not the CLL age and PS. It was a genetic biomarker, which is Ig heavy chain mutational status in the variable region. So the patient who have mutated IgHV, heavy chain mutated, they had better outcome with both. Whether they receive FCR or BR, it didn't matter. If they were mutated, they did well with chemoimmunotherapy. And the patient who had unmutated, they had poorer outcome. So I think understanding of this biomarker as well as TP53 are the second modern or third modern best breakthrough in the field of CLL, and we are still benefiting because we developed these because of the knowledge of this biology of CLL. We were able to develop drugs which can circumvent this shortcoming in the management of CLL. Next slide. Again, this slide is going to show you the same thing. IGHV mutation, patient who were receiving FCR. We will see 15 years follow-up of these patients. Next slide. So you can see after the gap of 15 years, there was a huge difference between patient who had unmutated versus mutated IGHV. So if there is a patient you have who is young and fit and who is having heavy chain mutated, you can rest and sleep well because their long-term survival is going to be very nice, almost plateau functional cure. And the patient who are having unmutated IG heavy chain, they do not do good with conventional chemoimmunotherapy. That is the bottom line. Next, please. Next. Yeah, so similarly on the line of mutation, now we have TP53 and deletion 17p. We all know TP53 is a difficult situation to be in for any hematological malignancy or for that matter, any malignancy. However, here it is important because deletion 17p and TP53 are not synonymous to each other. One is a mutation within a gene. The chromosome will be intact. On the other hand, deletion is a physical dislocation of a part of the chromosome. Both are independent prognostic marker for patients with CLL. So if you are kind of optimally prognosticating a patient, it is important to test for both deletion 17p as well as TP53 mutation. And I will show you that in the next slide. Next, please. You can see the patient who had only TP53 and deletion 17p was not tested. You can see there is a very clear difference between patient who are having this mutation or not. And on your right, you can see patient who had deletion 17p only. So this is also the widely separating curves in Kaplan-Meier survival. So these two are very, very important and independent prognostic markers. Next, please. Right, so I think knowledge of this, these two biomarkers as well as other like beta-2 microglobulin, the scientists could develop a very reliable prognostic marker, which is CLLipi. This is something which is a kind of breakthrough because for last 50 years, we use Rye and Binet kind of staging system. We are still using it. They are very simple. They are applicable at the bedside, but they had their own limitations. Now, with the knowledge of TP53, IGHV mutation, and other biomarker, we have this robust weighted score. And if you do it, you can also take a call whether to treat a patient or not, because the stratification of risk group after CLLipi has become very, very refined. Next slide. Now, coming to the last part of my presentation, which are the popular drugs. Needless to say, they are like popping apple. Probably the CLL is following the path of CML. Maybe in 10 years, we will forget most injectable drugs for CLL and we will talk the way we speak for CML. Next slide. Yes, go on. I think, yeah, before I go to the oral drugs. Now, most of the studies that we are seeing are with obinutuzumab. Obinutuzumab is a newer anti-CD20 monoclonal antibody, and often there is a kind of confusion that what is the difference between obinutuzumab and rituximab, apart from that being the second generation. So I would like to present to the audience the real differences between the two. This is only semantic, that it is first generation, this is second generation. The main difference is it is a type 1 IgG and this is a type 2 IgG, and these type of IgG differ in their ability to fix complement as well as attract antibody or other cells. It is shown in the last 3 rows. If you see complement dependent cell cytotoxicity, it is the major mechanism of rituximab, but it has very little application with obinutuzumab. Obinutuzumab mainly relies on ADCC and direct cell apoptosis. So you can see because of this cross difference in mechanism of action, obinutuzumab probably has ability to overcome the resistance seen in patients who have received rituximab in the past. So that is one insight into their mechanism of action. Next slide. Yeah, next slide. Yes, so you can see that clearly that obinutuzumab in combination with chlorambucil, in comparison to rituximab-based combination, showed high overall response rate and CR rate. And the icing on the cake was very high MRD rates seen with this combination. So if you see here on your extreme right in peripheral blood, the MRD negativity rate with obinutuzumab-based combination was 10 times that of rituximab-based combination. These are new fields for CLL. Earlier, we never used to speak about MRD in CLL. It was just controlling TLC, autoimmune feature and symptoms, and that's it. Now, MRD negativity as high as 37% is very exciting, and we are achieving these newer molecules. Next, please. And you can see this is the same is reflecting a clear-cut distinct advantage in progression-free survival with obinutuzumab over rituximab combination. Next, please. However, as I said in the beginning, it did not translate into overall survival, which is ultimate goal for any patient. So still probably we need to wait for longer duration. Next. Next. So Ibrutinib, we all know it is a Bruton tyrosine kinase inhibitor. It inhibits the downstream cell signaling pathway. Next, please. And this is a trial published in NEJM, which kind of in 2015, which established Ibrutinib as one of the main drug for CLL. Next, please. And you can see clearly the graph, it is almost flat graph. These are patients who had newly diagnosed CLL. And in comparison to chlorambucil, Ibrutinib was way above. Next slide. There are many, and you can see in the cohort, you can, I think, skip for the bottom of time. Next slide. Apart from, yeah, so you can see very well that apart from being superior as a single agent, Ibrutinib was also better for patients who are having IGHV unmutated status. Remember from the previous slide, IGHV mutation was one of the poor, unmutated status was one of the poor risk factor. Now, if you treat these unmutated patient with Ibrutinib rituximab, the outcome is far, far better than FCR. So needless to say that FCR or other chemoimmunotherapy have no role or pretty much very little role for patients who are having unmutated IGHV for CLL. The drug of choice, the therapy of choice is either Ibrutinib alone or in combination with anti-CD20 antibody. This graph tells that. Next, please. These are other studies in combination, and they are compared with FCR, they are compared with BR, they are compared with chlorambucil obinutuzumab. All the combination have shown a better PFS whenever Ibrutinib is used, and these are different trials in different cohort and population of the patients. Next slide. Briefly, a word about Ecalabrutinib, which is a newer second generation tyrosine kinase Bruton tyrosine kinase inhibitor. There is no head-to-head comparison between Ibrutinib and Ecalabrutinib. What we know today is that Ecalabrutinib is much better tolerated than Ibrutinib because it has very little off-target effect. Being a second-generation BTK inhibitor, it is more specific to BTK binding. If you see these target like TEC, EGFR target, and ITK. So Ibrutinib being first generation also used to inhibit them. So therefore, there were multiple off-target effect and side effect leading to drug discontinuation. But if you see Ecalabrutinib, it is very specific to BTK. Therefore, the side effects are very little. Majority of the side effects were either grade 1 or 2, and they were either headache or diarrhea, which were very easily manageable. Next, please. So it's the same thing. Next. And coming to the last part of my presentation, last couple of slides. Venetoclax, we know it is BCL2 inhibitor. BCL2 is an important anti-apoptotic gene, which is a very important regulator of apoptosis. Venetoclax inhibits it. And this leads to release of these pro-apoptotic proteins, which ultimately lead to cell death of a cancer cell. Next slide. So it was tested as a monotherapy, and directly it was tested in patients who were having deletion 17p CLL. Next slide. And you can see even with patient who had CLL with deletion 17p, the overall response was 77% with a single agent venetoclax, out of which 20% had complete remission. The icing on the cake was the patient who were previously exposed to Ibrutinib. They also responded to venetoclax beautifully. Their overall response rate was 63%, and 13% of them were complete remission. These were unseen, unheard results with any drug. So venetoclax came in a big way. Unfortunately, it is not available to us in India yet. Next slide. Next, please. And you can see This is slightly fuzzy here, but in combination, if you see venetoclax, this is finite therapy with venetoclax and obinutuzumab. It is far, far better than chlorambucil obinutuzumab. And this is the CLL14 trial, the latest most trial in the line of CLL studies. And this shows that we probably are moving towards a finite therapy, the way we treat a DLBCL patient. And it probably in the times to come, that is going to be reality for CLL. With this, I would like to summarize with next slide. That the major breakthrough, the best breakthrough we have seen till now is development of anti-CD20 monoclonal antibody. Obinutuzumab is exciting, but it is number one, very, very expensive, and we really still have to see the long-term outcome. We have already said chemoimmunotherapy is only for patients who are having mutated CLL for heavy chain as well as no deletion 17p. Next, please. Small molecules are there. They are exciting. People are using them. They are more acceptable by the patient and the society. However, the follow-up is smaller. We are already seeing discontinuation rate with Ibrutinib and their off-target effect. So we really have to wait for more studies and data. Next slide. The future direction, I believe that Ecalabrutinib will replace Ibrutinib in the years to come very soon. Obinutuzumab has potential to replace rituximab, and that is what most the pharmaceutical companies would like to see. The third point is that combination is going to be a reality, and we are moving from forever infinite therapy to a finite therapy in CLL. I would like to thank the organizer for opportunity. And next and last slide is a glimpse into the studies which are ongoing with the combination of all 3 and 4 drugs together. Almost the way we treat DLBCL, we give R-CHOP chemotherapy. All 5 drugs are given together for 6 cycles, and that's it. Probably that is the future for CLL. Thank you very much.